Hello and welcome to We Debate. I am Joe Munene. The COVID-19 pandemic in 2020 ushered in a massive disruption of our established social order and lives as governments across the world grappled with ways to manage on the pandemic. Hitherto unimaginable restrictions on people's freedoms, movement, and social interactions were enforced. In Kenya, the government took restrictive actions based on the regulations such as the Public Health Act, the Public Order Act, as well as the Constitution. But in the eyes of the Constitution and in its application, should the one right of safety and public health concerns override other rights such as the right of freedom of movement and association? This is good for debate.
The debate motion for tonight. Let it be resolved. Public health emergencies justify the restriction of the constitutional rights of freedom of movement and association.
Dr. Sultani, Siti Muga, welcome to this debate session.
Thank you.
The motion before us, let it be resolved, public health emergencies justify the restriction of the constitutional rights of freedom of movement and association. Dr. Sultani, you are on the affirmative side of this motion. Siti Muga, you stand in opposition to this motion. Now, a quick brief on the flow of this debate. We will start off with your opening statements. You will each have 1 minute to make your quick opening remarks. After that, you will have 4 to 7 minutes to give your main presentation on why you stand on the side that you stand on in regards to this motion. After the second main presentation, we'll have rebuttals, your chance to respond to your fellow debaters' position. As part of the format of these debates, we have a panel of jurors, 3 jury members who will be listening and scoring on your respective arguments in these debates. And prior to the start of the debate, the jurors have been polled to establish their individual position. And 2 out of the 3 jury members are in support of the motion. So Dr. Sultani, you start off with a head start. Siti Muga, a lot of work, but 1 of the jury members is on your side. At the end of this debate, we will poll the jury members again to establish whether you've been able to sway them to your side of this debate. To our viewers back at home, we are also polling this question on our social media pages. So please let us know where you stand even as the debate progresses. So we start off with the opening remarks from Dr. Sultani.
So thank you very much for having me. I would just like to start off by saying that I strongly support this debate motion because, public health emergencies, generally they justify the restriction of some of these constitutional rights of freedom of movement and association. And in the discussion, I'll be able to justify why it is important that we actually look at these constitutional provisions, because maybe just to start it off, you'll find that these public health emergencies, they have a very important impact on our lives and livelihoods. We are just grappling with the COVID-19 pandemic, which is going to be used in the discussion as a basis to even be able to illustrate the points that I'd like to put across. So I think I just want to really say that it's important for us to look at this important intervention where we have to allow the constitutional provision to be put on stay just to allow us to deal with these public health emergencies. Thank you, and back to you.
All right, thank you. Siti Muga, your opening remarks.
I want to thank the organizers of this debate for the foresightedness in presenting debaters with an opportunity to discuss a much valued topic. I want to thank the gentleman on my immediate right for agreeing to come and propose this motion that in my view is a fairly hopeless one, because the facts are clear and obvious, and they'll become apparent to all those who will be listening. The topic in itself presupposes several things. It presupposes that there are only 2 sides to this particular discussion. Any discussion on public health cannot have 2 sides. It has a myriad of sides. And The side that I'm certain my worthwhile co-competitor will focus on is the medical aspect of it. And yet, when you talk of public health, when you have a drought, it presents public health issues. When you have famine, it presents public health issues. When you have a war, it presents public health issues. When you have flooding, it has public health implications. So the discussions around this goes beyond the boundaries of known medical science intervention, known public health interventions. But it also caters and looks into the history that we have in dealing with what we are referring to here as emergencies. And I'm going to ask that question even as I talk, as whether these emergencies are, as we state, emergencies, or they are just figments of some people's imagination and a laziness on their part to deal with the real issues. And instead of actually looking at it as they should, they prefer to give it titles that will inflict fear and despondency. Emergency.
All right. Thank you, City Muga, for your opening remarks. Now we circle back to you, Dr. Sultani. Your opportunity for your main presentation. You have 4 to 7 minutes.
So thank you very much. I want to just start off by appreciating the fact that constitutional provisions are to be respected. And in this case, I think I do not contest the fact that the constitutional right, everyone has a right of freedom of movement and freedom of association. But then we also really have to look beyond this, in the way it is printed out. And we have to also consider the fact that these constitutional provisions apply to everyone. They do not apply to certain individuals and leave out others. In this case, I mean that whereas you are enjoying, Mr. X is enjoying their constitutional right for freedom of movement, they also need to make sure that they are not infringing on the constitutional right, the same constitutional right of individual Z. So we have to come in as practitioners of public health to ensure that we are protecting everyone equally. And in fact, it does not just apply to public health alone. And I think as my worthwhile discussant has also put it across, you cannot just allow somebody to move into private premises or restricted premises or security installations. We have to have, we must have some exceptions to these constitutional rights for obvious reasons. And in this case, we are looking at, we are looking at the need for us to be able to preserve lives. We are looking at the need for us to be able to preserve livelihoods. The economies around the world have been brought to their knees. Case in point, Kenya not, spared. We must be able to make sure that we are preserving lives and livelihoods. And this is not something that has just happened in Kenya. It has happened all over the world. We have seen unprecedented measures being taken, where even transport has stopped across the world. Of course, these public health emergencies, we need to look at public health in several focus points. Number one of the things that we are trying to achieve is to ensure that we prevent the emergence of these health emergencies. Number two, we want to be prepared for them so that when they occur, because however much we prevent them, when they occur, we will need to deal with them as fast as possible. Number three, we will need to respond when they occur. And then number four, we'll need to recover from these public health emergencies. So in one instant, we are looking at the need for us to be able to work on number one, which is prevention. And these restrictions that we are talking about really feed into prevention and preparedness. Otherwise, we'll find that the public health emergencies are coming in, and before we figure out what we need to do, we've already lost lives. I will just zero in on one example, which is, I think, the COVID-19 pandemic gives us a very good platform. And you remember that at the height of COVID-19, when there was the outbreak, the pandemic, there was a lot of strain on our resources, our public health resources. By that time, we had very limited ICU beds. The number of ICU beds across the country was limited. The capacity to provide oxygen was limited. And we were facing a danger of having too many people coming down with COVID, requiring ICU beds, requiring oxygen, and yet it is not there. So one of the things that we had to do was to limit the spread of these, this virus, so that even though we are having some people who are falling sick, the facilities that we have at that time are able to handle the need that these people have. Now, we have since seen a big improvement in the capacity that we have towards being able to handle such an emergency. And that is why you'll realize that today, although the COVID pandemic is still on, we have relaxed a lot of these restrictions. So these restrictions are not punitive in nature. They are strategic to ensure that everybody who requires healthcare, everybody who requires preservation of life has a fair chance at it. Whether you are broke, whether you have money, you have an equal chance at accessing healthcare. And that is what we need to do so that we make sure that the facilities, the scarce facilities that we have, are able to meet the needs of everyone who needs them. And as we continue expanding the facilities, then we can be able to relax the restrictions and allow people to enjoy their freedoms as much as the situation can allow. Thank you, and back to you, moderator.
All right, thank you, Dr. Sultani, for that presentation. Siti Muga, I'm not sure whether you've been convinced by that presentation at this early stage, but this is your opportunity to give your presentation.
My fellow debater is definitely an eminent practitioner of public health. He has the knowledge, and perhaps the movers of this motion yet have a hope in my fine co-debater here, because everything he has presented is actually true. But there's a however following what I'm saying. However, if you look at the history of what we call medical science, just a brief history, nothing too long, nothing too elaborate. I want to take you back into history because in the absence of understanding our history, there are those who argue you cannot understand our present, neither can you have even the remotest chance of figuring out what the future holds. We're talking about the 1300s. Something happened on this planet that had never happened before. It was called the bubonic plague. 50 million to 200 million people died. Now, sounds, if you're talking about now, when we're in the billions of numbers, you figure 200 million. At that point in our history, the population of the world was something like 392. That was the population. So that particular plague literally wiped out close to half the population of the world. There have been many plagues. In our time, HIV, which still counting though, 36 million people died, we're still counting. We have COVID, numbers still counting. Lessons were learned. And the lessons that were learned were lessons that were put into practice over time, and that's what gave birth to what my erstwhile colleague here has studied, what you're calling public health, epidemiology. That is what gave birth to it. Medical science understanding that there is a need to approach these diseases, especially when they're widespread among people, through research, through education, through other means other than just strict clinical care. Now, what does the 21st century tell us? This is the information age. That we've come of age with our science, with our understanding, and with our knowledge of healthcare, and we can see in the way everything around healthcare has improved. But have we kept in mind the lessons that we have learned? If you look at the thread, these epidemics were diseases that spread around large numbers of people. Medical care, as we knew it, as we know it, that centered around clinicians, people who are trained for clinical care, would never be able to cope with it. We saw it with COVID. It was clear. What then was needed? What was needed was what we refer to as the preventative aspect of healthcare, meaning you don't wait for the disaster to strike. No, you prepare for it. The pandemics of the past taught us that we need to be prepared. Let's spread it. If there are areas that flood every year and you know they flood, surely are you saying there's no solution to it? There is. There's some flooding that are caused by what we call global warming that difficult to prepare for. But if you have structures in place, what it means is you are able to save lives because of your preparedness. You are able to, the word is mitigate. The same with diseases. There is a need to understand that when you talk of public health, you are talking of engaging the public. Not in trying to provide healthcare for them, but getting them to be partners with you in ensuring that their lives are taken care of. If you don't engage them, then it can't be public health. It's something else. If you look at HIV, it taught us the best lesson in engaging the communities to partner with you. After we learned the lesson, what did we see? We quickly forgot. So when you look at this topic that we have today, public health emergencies justify restrictions of the constitutional right. Justify. Oh no, they don't actually. The emergencies explain to us with clarity how quickly we forget. They explain to us with greater clarity how quickly we like easy solutions. And that's where the curative aspect of healthcare comes in, where there's a tablet, there's an injection, there's something or the other that you're given, and it takes care of the immediate problem, but it's taking care of the consequence. It's not taking care of what is bringing it about, what causes it. It doesn't take care of that. Now, until and unless we are in a position to understand this need to be able to look into issues and prevent them from actually occurring or limit them to the point where they stop being an emergency, then healthcare will continuously be at risk of being overrun by diseases. Why did we see the high death toll in Europe? Well, it wasn't for lack of preparedness, but it was a lack of forgetfulness. Forgetfulness on their part. Many of them had stopped practicing what we call primary healthcare a long time ago. And many of them have aging populations. So when you had a disease that focuses on people who are old like myself, suddenly you find a situation where they do not know what to do because the very thing that could have helped them, they neglected and forgot. The thread that runs across our healthcare systems is that we have the solutions, we know what to do, we are prepared for it, but we forget, we neglect. So the problem isn't so much an issue surrounding our rights, the freedoms and associations. Oh, no, it isn't that. How do we prevent ourselves from forgetting, and how do we continuously and consistently apply the lessons that we have learned over time?
All right. Dr. Sultani, your response to Citi?
Yeah, thank you very much. I want to also agree with my fellow discussant around the need for us to be able to learn from experience, and also agree pretty much with most of what he has said with regard to public health. And I'd like to say that we have learned a lot from the COVID pandemic, and probably to also just confirm that we really need to have a strong preparedness mechanism so that we can be able to deal with some of these public health emergencies. What I'd like to emphasize is the fact that whereas some of the previous pandemics, I think we have even been able to use the available data to estimate that pandemics will keep on coming at 100-year cycles. But this is before the globalization that we are experiencing today. You'll realize that today the world has been turned into a global village. Today someone can have breakfast in New York, have lunch in Europe, and have dinner in Nairobi. So you'll find that if we are having communicable diseases, these diseases can travel around the world several times over within 1 day. So it is important for us to be prepared for the next pandemic, which will definitely come much, much sooner, not even just sooner, but much sooner than the 100 years that we are talking about. So what have we done? I think for us, the COVID-19 pandemic has taught us a lot. Currently, we have established a National Public Health Institute, which is going to lead and coordinate public health functions in Kenya, so that by the time another pandemic of the magnitude of COVID-19 strikes, we will be much better prepared. And in agreeing with my colleague, we will be much better prepared for it, so that immediately we detect it, we are able to contain it at source and we don't have as many casualties as we have seen with this particular pandemic. Number two, we are actually, and I want to agree with my colleague that data is very important, and we are putting a lot of emphasis on the use of data to be able to predict and to plan and to make decisions with regard to public health emergencies. So that next time, instead of shutting down sections of the country, we will probably be better informed to be able to shut down, with better precision. Because this time, if we had the kind of data that we are generating today, probably we might have allowed a little bit more space for movement. But in public health, we do not have the legacy to be able to wait until we lose lives before we act. And my colleague has given very good data, which I can say we are now collecting even here to be able to use to make such decisions. We will be able to engage the public much faster. You have been able to see that every single day we are collecting information about the cases of COVID-19. And every day without fail, because there is a lot of work that is going in. It's not that we are now just sleeping on the job and waiting for easy solutions. We are actually, teams are out there every day without fail. I receive a notification of how many people have been tested for COVID, how many are positive. At 1 o'clock on the dot, today I've already received that information, because our teams are out there collecting data which we can be able to use to be better prepared next time. Another thing that we are going to be able to do much more effectively, which we are already doing, is engaging the community in what we call risk communication and community engagement, RCCE, which is of course dependent quite a bit on data. We have improved our capacity for ICU beds, I've said that. We have improved our capacity, significantly for oxygen capacity and needs. We have improved our ability to conduct laboratory tests. We are now able to conduct some of the most sophisticated laboratory tests, including genomic sequencing, which was not available at the onset of the COVID-19. Today, even if we have another variant that comes in, we will be able to detect it very fast, and we will be able to confirm that this is a different variant so that we can be able to report on it. So I think generally in agreement with my colleague, we are doing much more, and we are getting better prepared for the next pandemic, which will come much sooner than we expect. Thank you, and back to you.
All right, Siti, your response?
It isn't every day that I have the privilege of debating with someone as prudent and someone as far-seeing as my friend here, who has agreed with literally everything I have said. I thank him. When I look again into history, I go back to 1928. There's a gentleman by the name of Dr. Alexander Fleming, the father of what we nowadays call antibiotics, but in his time, he understood what we then came to give the name penicillin. Okay? Fast forward, we have HIV. ARVs came into being. Before they were proliferated and could be afforded, what was given to HIV patients was, first of all, you're given multivits, you are given food by prescription, which is a concoction which you could make into a porridge, and you're given a broad-based antibiotic to cater for any opportunistic disease. Then came research, sustainable research, sustainable East Africa research on community health, SEARCH it was called. And the research that was conducted came to one conclusion. The only way you could fight HIV was you test and you treat. Not test, wait for the viral load to sort of like come down to a point where you could manage. Test, it doesn't matter the level of viral load, you treat. Now, when it comes to the diseases that take people to hospital, basic diseases like diarrhea, pneumonia, malaria, there was Integrated Community Case Management, ICCM. The research was conducted in Homa Bay County. And one of the findings, a 3-year research followed by a 2-year follow-up, was that 75% of hospital attendants sort of like went away, meaning the numbers of people who went to hospital for care was reduced by 75%. How did this happen? Very simply, villagers, community members were taught how to diagnose and treat at the village level malaria, pneumonia, diarrhea. Simple. Now, arguments still arise about it, but the evidence couldn't be argued against. So when my colleague says he agrees with me, he's a public health practitioner. He knows what he's saying. And he is right in everything he's saying. My turn to agree with him. He is right. And he's right because when you look at the steps that have been taken, you cannot say it is nothing that has been done. Where the problem arises, again, is in implementing the very things that have proven to work and making sure you implement them continuously so that people can actually benefit. It's like they implemented during the research period, during the follow-up period. Thereafter, when it is left in the hands of those who are supposed to manage it at the county levels in this country, then suddenly everything falls apart and suddenly you're beginning to wonder. If you recall, one of the biggest debates during the time that we're dealing with COVID was community health workers. Who do you get? And why community health workers? Community health workers tend to be locals. So when they communicate the message you want to communicate, they're communicating to people who know them and people whom they know and people who will easily trust what they say, not experts whom they don't know and whom they don't fully understand. And they're able to communicate in a language that the locals will easily understand. After all, they live there, they're locals. But it's a debate that continues to dog our healthcare system. Whether to have healthcare workers, how many should we have? How should we train them? So long as it's a continuous discussion and not an implementation discussion, then the problems we have, as my erstwhile colleague has mentioned, with the next pandemic will be exactly where we were, scrambling and trying to figure out what to do, and yet a structure of people who are trained to manage community expectations and to communicate serious clinical, medical issues to the communities have not been sufficiently deployed.
Well, that marks the halfway mark of these debates. We will be back in part 2 with a series of questions and answers, starting with the debaters, cross-examination, and then we'll cross the floor to the juries to question our 2 debaters. For now, we take a short break. We'll be right back. Welcome back to the debate. A quick reminder for you to engage with us on our social media pages on these debates. We start off this second half with cross-examination between the 2 debaters, and we will start on the negative side. Siti Muga, your opportunity to ask 2 questions. To the affirmative side, you could ask sequentially or question and answer. Over to you, Siti.
Okay. One of the things that public health practitioners do when they're applying their trade is they do something called costing. And they employ the services of people who are experts in costing, as well as what they call health economics. Now, when you look at the cost of pandemics, do you think that nations who prefer to restrict their citizens and to infringe on their rights consider the cost of such actions?
Okay, so I would like to start by saying that when we look at the effect, of course, the effect of the pandemics and the public health emergencies on economies, then that is definitely taken into consideration. Because we are looking at a situation where, on the one hand, you want to allow, and I think we have observed the authorities really being at pains, even when they are imposing these restrictions, looking at the impact that it is having on businesses and other activities that help us to be able to advance our economy. But at the same time, we have to look at it in terms of how is it going, the pandemic itself, how is it going to affect our economy directly? Now, one of the things that we look at as public health practitioners is we need to look at these the interventions we are making as investments. So it is not an expense. For example, we need to put in more money as governments to now improve our preparedness for these public health emergencies. We have to put more emphasis on what you talked about earlier, the preventative aspects, promotive aspects of healthcare, so that we prevent these public health emergencies from happening rather than reacting to them. Because when we wait for them to react, then we are held in a situation where we must take these decisions that are curtailing economic activities. I know that in Kenya, we have one of the most progressive constitutions, and it touches on issues around the devolution of healthcare, so that there are some functions that are supposed to be carried out by the national government, and there are other functions that are supposed to be carried out by the county governments. So probably one of the things we need to look at is when we are looking at the health economics, how well are we financing the functions of the county governments vis-a-vis the functions of the national government? And then we go deeper and determine how well are we utilizing the resources at whatever level, so that we can be able to make sure that each level is meeting its obligation in making sure that we have a properly functional public health system where we are able to prevent the public health emergencies, we are able to prepare very well for them, and then we are able to respond as fast as possible to the public health emergencies.
Dr. Everything you say is in the future.
Yes.
Can, will, might. With all these huge budgets that we have, really, in all honesty, if the governments, let's say of this particular country, Kenya, were actually willing, that they are able to, no doubt, that they can, yes. But where are the examples of them doing these things that we are saying? Are these things done in the dark when we don't see them, and come daylight, they disappear? Where are they seen? Where is there evidence that these things actually get done?
Yeah, so there's a lot of evidence of what has been done so far to try and make sure that we are better prepared for public health emergencies, especially at the level of national government. We have just talked of reorganization of the sector, so that we have a national institution which is responsible for leading and coordinating.
See, Dr., we are getting back.
Public health functions.
You see, we are still in the future.
No, this is something that has already happened.
And what are the tangible results that we see from this?
Now we are seeing better coordination. We have seen, the expansion of some of the countermeasures. When we have public health emergencies, we are able to react much faster. We have better bed space. We have better capacity to provide, emergency treatment, oxygen. We have better diagnostic capacity. And we hope, actually, we have to also think futuristically, so that we hope that in the future we will even be able to do better. And then we can even allow people to move around freely, in the threats.
Let me step in on this specific issue of, does this justify the restriction of other rights? Why is the right to good health, and yes, we know it's important.
Yes.
But why does it trump all the other rights? For example, in terms of restriction of association and movement, other rights such as the right to socio-economic well-being was affected, the right to education was affected, the right to work, the right to assembly. And I think where City is coming from is that if we have a proactive approach, then we have a much better chance of ensuring that these other rights are not trampled on. So just to hear from you, why is this one right? Why does safety trump all these other rights?
So maybe if I can just paraphrase and put it a little bit more directly. For us to enjoy these other rights that you're talking about, we need to be alive, yeah? Mm-hmm. Yeah, for us to enjoy them. So it is important that we, first of all, we preserve the life, yeah? So that we are there to even enjoy these association, education, and so on. But I also talked about these rights in themselves. We also have to look at them in the context of they need to be enjoyed by everyone. So if we find that there is a segment of the community that is now infringing on the same right, of the other segment, then we have to come in and see how do we now try to prevent this segment from infringing on the other segment.
Okay.
Yeah.
City, maybe you will respond, but you have one more question, and then we take Dr. Sultani's questions. Too.
Let me begin by making a statement. That's a lazy approach to dealing with this issue, because if every time you have an emergency or something you need to deal with, you justify restriction as being the only way forward, and yet, even from our discussion, it is clear that we could have had a preventative approach to it, which, by my estimate, is a far more cost-effective way than the curative approach that we keep shoving down the throats of the taxpayer. Now, if that isn't there, and there are no signs of it being there, then we can't talk about the willingness, because the willingness is measured by what is done. So they can talk about willingness and the future and what they hope to do, but the evidence, unfortunately, trumps it completely. There is no willingness because you do not see anything happening. Now my question, is it possible to promote and to ensure that we have the preventative aspect of healthcare entrenched in our healthcare system?
Absolutely. I think probably those are we are speaking about the same thing, but maybe using different words. So number one, I would like to say that in January this year,
yes,
we have a National Public Health Institute established to be able to advance these issues around making sure that we have better capacity to prevent and prepare and respond. Number two, we also have, in fact, the other day, the Cabinet Secretary for Health launched the Kenya BioVax. So we are looking at, in the future is about making sure that people are vaccinated, people are more resistant to the impact of some of these pandemics. And as a country, we are putting in resources to ensure that we have better capacity to produce our own vaccines and to be able to protect our people. We have also seen even the head of state actually presiding over agreements being made between Kenya and Moderna, which is one of the leading producers of vaccines, so that apart from even just the COVID-19, we have capacity in country where we can even support not just the country but the whole region to be able to produce important supplies like vaccines in the case of future pandemics. And this one, we are actually talking about supporting the whole region, not just the country. Something like the COVID-19 was unprecedented. We have never really experienced such a thing. And I remember even in the beginning, we were really trying to do a lot of research, trying to check and see what is this. It is like an enemy we do not understand. We are not prepared for it. So even as we are trying to fight it off, we are also really quickly trying to build capacity. And that's why in the beginning, we had to go to extremes. It is not that this is the number one option for us to be able to handle such emergencies. We are saying that it was an unprecedented situation. It did not happen just in Kenya alone. It happened all over the world. The whole world was taken by surprise. And what we are trying to do is that in the future, we will be much better prepared so that we don't have to restrict people from accessing some of those rights, so to speak. Thank you.
All right, now a chance to you, Dr. Sultani, to ask two questions to weaken City's arguments so far.
Okay, so I want to maybe just start by asking, because you have laid a lot of emphasis on the need to be prepared and to focus on prevention,
yes,
rather than curative services.
Yes.
And you have actually labeled that as a lazy approach.
Indeed.
So I just want to hear a little bit more from you. Why do you feel that there is no adequate capacity for prevention? And what do you propose would be the ideal way to go about this so that we can be able to meet the standard that you are envisioning?
Thank you for giving me the role of the Ministry of Health and also the Ministry of Finance, because if we have ideas, they need to be funded. So now in my capacity as the Minister for Health and the Minister for Finance, I have the following to say. We cannot judge what we do and measure it by the standards of the West and presume that what the West is doing is the yardstick by which we must follow. We were able to escape the scourge of COVID for, among other reasons, the fact that we have a youthful population. You will not be told this. It is written, but people don't talk about it loudly enough. We have a youthful population. There are those who argue, this one, I don't have evidence scientifically to prove it, but the fact that we are in a third world country like the one we have, we are beset by diseases on every other day. So our immune system, it could be argued, is really very robust. So one other disease coming along, I think the system tells the disease, just join the queue. There are others who are before you. Now, if you look at what the West have done, why don't we look at the things we have done and we are ahead of the West? The West is grappling with global warming, greenhouse effect. We here, this country of Kenya, independent country of Kenya, 95% of our power production, clean energy. Here, clean energy, we. Even the West don't have what we have. So if we can do this in energy, why can't we do it in health? What's this big, complicated thing? The biggest foreign exchange earner in this country is what you call remittances. People who've gone abroad send money home. We export labor. We are a net exporter of expertise, and they earn us money. It means we have enough labor for ourselves, so we let our neighbors have. So this focusing on building labs, it's a good thing. You want to build a vaccine factory, it's a good thing. But if I may speak anecdotally, why do you want to help your neighbor build a house and you can't feed your own children? Why? Do you have your priorities right? It's a question of priorities. Now, in my capacity as a Minister for Finance and Minister for Health, this is what I would do. I would go back into history and look at the system where we had people who did precisely what I am suggesting. We had individuals whose work was to go to the village, because they were stationed in the villages. They were to educate villagers on primary health care, boil water, do the other. They were supposed to help them understand basic fundamental agriculture. They were called extension workers. They existed. This wheel we don't have to reinvent. We just need to add more spokes to it, make it broad-based, and give it aluminum. Just make it look shiny, but we already have the wheel. That is what I would do. Because when you have the preventative aspect of healthcare, the truth of the matter is you are investing in something that will give us the very same thing that my friend was suggesting, a healthy nation. Because people will stop being sick as frequently as they fall sick. And once they do that, the cost of treating them will automatically go down. So even when we talk about health budgets, the budgets will be going towards other things other than for treating people for diseases that could easily have been prevented.
Okay, so it brings me back to what I was saying earlier, because you have just said it yourself, that we need to bring all the other sectors on board.
We do.
Now, I agree with you, and we learn from, everything in life is a lesson. And, it's only tragic if you don't learn from it.
Yes.
We have learned that public health functions in Kenya and in many other parts of the world are fragmented and spread across sectors.
Yes.
So you'll find that something is being done in the water sector, which is also being done in the health sector, and they are not communicating.
Yes.
So there is wastage of resources, there is duplication of effort, there is lack of leadership. And so when such public health emergencies come in, they actually now, it takes very long for us to respond, and we have a lot of casualties. That is why we have established a National Public Health Institute to lead and coordinate public health functions across sectors. That alone is going to actually have a big effect on our ability to be able to respond on time, because all sectors now do not depend on one sector. The health sector will be supported by this institute, just the same way the agriculture sector or the livestock sector will be supported by the same institute. The trade, which is also a very important sector in public health, will also be supported by the same institute. Security, because we have lost 5,000 people to COVID-19. In fact, it far outstrips the number of people we have lost from external aggression, you know. So this is something that is of national security proportions. This institute is going to be able to make sure that all those sectors that are involved in public health functions work in a coordinated manner, and we are able to handle these public health problems at source. I'm not saying that all that you have said is wrong.
Of course you are.
But it is important for us to, actually you have put out some very important points, which some of them we are working on, yes. Some of them we are picking up so that we can work on them. But at the same time, we are doing quite a bit to ensure that we learn from what has happened so that we can be able to make sure next time.
Forgive me if I doubt you, because you see, everything that you say makes so much sense, but where do you see it? You see, one of the things that isn't done adequately is government doesn't talk to its people unless it's absolutely necessary. And even when they do, the information is given in little bits and pieces, which they feel it's like food for an infant, just a little bit so that you don't choke on it. Surely. How do you expect the public to walk with you?
If I was to ask, given what Dr. Sultani has said,
yes,
all those measures, all the capacity that was built in, are we, in your view, better prepared to handle?
No, we are not.
Another scenario of a
far
pandemic.
from it, far from it. We even have a unit in our system that is supposed to cater for disasters, isn't it? Disaster management. We have a situation where the number of people who don't know where their next bill is coming from has risen to 4.2 million in the country, 4.2. So this unit that does management of, that's a disaster, by the way. This unit that's supposed to cater for this, so what are they doing? Interventions that you hear of, yes, the government takes part, but you'll hear UNESCO has given this. You'll hear some other agency has given this. So then you hear 2 billion shillings have been set aside. You hear, and then the story dies. You don't know what amount went where and what specifically was given, and the breakdown of what this thing actually did to alleviate. Because if the numbers of those who need food, basic sustenance, keeps rising, then how effective are these things, in all honesty? Because I thought simple arithmetic, they ought to be going down, not going up.
All right. We now give a chance to our panel of jurors to ask questions. We'll start with juror number 1, Mugambi. You indicate the person to whom your question is directed at. We'll try and balance it out so that each of the debaters has 2 questions from the jury panel. So one of you will need to ask 2 questions. Whether that's you, Mugambi, go ahead.
All right. Thank you very much. Thank you for the robust debate. Just going back to the topic, it's about restriction of constitutional rights, which I don't think we've really captured well, because if you're limiting constitutional rights, it has to be specific, it has to be measured in several aspects. Whose rights are you limiting? For what period of time? Who is going to carry out that policing? Okay? Now, I think what Dr. Sultani is stating is that rights were restricted blindly. And when you restrict rights blindly, then there is an adverse effect to many other rights. I think it was mentioned, right to education, etc. So how do you balance these rights, and who determines which rights are to be limited? When do you determine when these restrictions are to end? Who carries out the policing? Because remember in Kenya, I mean, when the pandemic started and these restrictions were on course, is that it was violence by security agents on the people of Kenya trying to carry out this restriction of freedom of movement. And further, there was restriction of other rights. For example, the right to privacy. When you're getting into the country or moving, they started information that was demanded upon you. Free speech. People could not openly criticize the interventions that are being carried out because that was taken as misinformation, fake news, etc. It was labeled as. So our free speech was also limited. The right to dignity. I mean, if you restrict my movement, I can't go to work, I can't earn a living, that my dignity, there's a challenge into my dignity, access to information. I think Mr. Moga has talked about it. To what extent do you justify to the population that we need this restriction? That was really poorly done. then the government using the states, not only in Kenya but all over the world, using this as an opportunity to police certain segments of society. Journalists, people in civil society, and academics who have something to say about these issues. So how do you balance the rights? How do you determine the proportionality? When do the restrictions end? At what point? And I think this, my question is better answered by Daktari here.
So thank you very much. I think that's a very good question because it brings everything into context. You'll recall that I said when this pandemic struck, and it applies to most of the public health emergencies, when COVID-19 broke out, this was not a Kenyan situation. It was not unique to Kenya. It was global. And you'll find that we were now dealing with something new. It is a new novel virus. We don't know about it. So we are trying to learn as we move. And you could see that the measures were applied across board. So one of the things that we are looking at now, we are learning from this circumstance, is how do we now move away from now policing people into doing what they are supposed to do, to now having them do it out of better information, you know? It takes time. If we would have said, let us allow, you know, let's allow people to choose whether they want to wear masks or they want to go to work or they want to move around at night and go to social places and so on, probably we would be dealing
people
with
were challenging the effectiveness of those measures. I mean, there are people out there, I mean, social media, they will say, these masks are not effective. And there was research online, I mean, you can call it fake news or alternative news, but there are people saying, yes, this restriction, you're telling us to put on masks, but it's been shown these masks don't help. You're telling us don't restrict our movement, but does this really help? So it goes back to the question of proportionality. How do you balance these rights? Because you're adopting a very paternalistic way about it.
So
you're saying we know better, and we're going to force this on you.
The research you're talking about, how valid is that research? The one that was informing the positions that were criticizing
how valid is the research that you are depending on?
Very valid.
Actually, that research, I have to agree with him, that research is valid. And it's not just because of COVID, it's research that covers, should we say, many other diseases.
Yeah.
The point here is this.
So when people come out and start speaking on social media that research has shown that, you know, then they come up with a very weird finding that we cannot find anywhere, you know. There is no peer review of that. It is just someone who has put it out there, and there are so many comments on that post.
But Daktari,
do we now adopt it just because it has come in social media?
Those in the research field, those who work in the research field, I think, are to blame partly because they live in their own little silos. Unless you are in the world of research findings, the publications, unless you have an interest, you will not know. And yet, there are very far-reaching consequences. So again, the issue of communication, making sure that people actually know what you know. In the absence of that, the public will take what they know to be the absolute truth because there is nothing to either augment or to refute whatever it is that you're saying.
Dr. Ruguru, how many questions?
I have 2 questions.
Okay.
One to Dr. Sultani and the other one to Siti Muga. So it's been a very interactive and interesting discussion. So Dr. Sultani, we can start with you. So we can say that monkeypox was identified in 1970. We also had cases that came, into the non-endemic countries in May 2022. The numbers are rising. We're currently at 1,158 mortalities with a mortality of 11%. So you've been saying that we are having preventive measures being taken up to ensure that these pandemics do not have the rise of mortalities. So let me ask, we can see it's going downhill, and it was recently declared as a public health emergency. What do you think is missing? Because we can see it coming, but it still goes downhill. What do you think is missing?
Yeah, so I think it takes time for these for the systems to be put in place and to be fully functional. But I can tell you that that it's looking really good. I know that the monkeypox challenge has come in, and it is at a time when we are still trying to figure out how to work between countries. The global health security agenda, it's something that countries are working on so that we don't look at our situations in isolation. Just the other day, we were discussing at global level how to put in place a pandemic preparedness treaty. So this one, and there are other approaches that are also being considered. We have the International Health Regulations 2005 statute that has been already passed by WHO. So we are trying to see how do we activate country-to-country collaboration so that even if the indexed case is found in West Africa, we can all collaborate in making sure that we handle it at source and we don't wait for it to come to us before we can be able to deal with it. So those are now some of the issues that we are looking at. But in country, I can assure you that a lot of the countries have worked on their capacity to prevent, prepare, respond to public health emergencies. It is much better now. It is just that it is work in progress and it is continuing. We are not letting the guard down just because we are now seeing fewer cases. Of course, even the fewer cases are because of the countermeasures that we've put in place.
Okay, thank you.
You had two questions?
Yes. So to Siti Muga, so when you're finishing your introduction, you asked whether these are real public health emergencies and whether the statistics are actually real. So my question is, what do you think are the other alternatives of dealing with these public health emergencies, if not curtailing freedom of movement, whereas there's proof that these diseases are spread by in-person contact, respiratory spread. So what do you think can be done?
See, the restrictions, according to the topic that we have here, is something that is imposed. You are told you will not move, as opposed to this is the situation that we have and this is what we are proposing. Sweden attempted this approach. And the scary thing was at some point, not the number of deaths, but the infections just kept rising and rising. And there was talk of getting to a point where herd immunity would kick in. It did kick in, but not at the point at which they expected it. Now, their approach where the citizens are actually given a choice, they are managed. You're told, this is what we expect you to do, this is what will help you, but please choose. The number of students who can go to school or in a class would be this, meaning their whole discussion around how to manage it was very different from what the rest of the world was doing. And I'm saying this, because the bulk of our population is still in the rural areas, their healthcare seeking behavior doesn't have to get to the point where they're absolutely sick and dying for them to go to hospital. The preventative approach becomes critical. Now, I also said it is a lazy approach because this position where you have a population who is not only well informed, but whom you carry along with you with your discussion, it is not something our government does. Ours is a top-heavy communication system where you are told what to do. Even if it's good for you, you tell even a child, they will resist it. If you carry them along with you, the very same measure, and over a period of time, it isn't instant, they will understand that when the government says something, it is in our interest, they will comply. But so long as you don't carry them along with you when you're having this discussion, and you make it something continuous, and it can only be done if you have a workforce that works in the health system within the communities. We don't have a big enough cadre of that particular person or people. So as far as I'm concerned, we can talk about justifying the abrogation of these rights. But you see, this is the problem. When do you actually stop? And when do you start to get the citizens on board in understanding that your government and you can have a conversation, as opposed to the government will continue telling you what they think you should do?
All right, Dr. Ken Soy,
Yeah,
your question is to?
My question goes to Siti.
Siti?
Yes,
Go ahead.
Thank you very much for the very engaging debate. I think you've really defended your position, arguing with the government of Kenya. Yeah.
I am the government of Kenya. You forget that I am the Minister for Finance and Minister for
You
Health.
are the Minister of Finance.
Yes, so
and
you are suggesting
Minister,
I'm arguing with
Minister
myself.
Of Health.
Yes.
And I think Dr. Matende Chero also has experience arguing with the government as a union leader. So it's a very good panel we have here. So my question goes to you in your capacity as the Minister for Health and the Minister for Finance. And you are confronted with evidence because numbers don't lie. Your technical people have presented to you two cases, a case of the United States of America, with their freedoms deeply entrenched in their constitution, and their rights to move around, to even things are being challenged in the Supreme Court, that wearing a mask is unconstitutional and things like that. And a case, and you look at the death toll from COVID in the US. They are at, I believe you've done your homework. There are over 1 million deaths, yeah, from COVID from the US. And you look at China, or maybe to be less extreme, even Australia, yes, which took very drastic, I could say drastic draconian
Throw in
measures.
New Zealand while you're at it.
Yes.
Yes.
From the very beginning. And they, despite having a large population, we only experienced 11,000 deaths from COVID. That is reported. China reported 5,000 deaths, same number as Kenya. So in your capacity, which line do you choose? Yeah, confronted with that evidence.
We have a constitution that guarantees our population certain rights. The Chinese constitution, I don't think, is similar to ours. They could argue that they're following their constitution. And they could argue that that is the way that their system works for their people and the numbers that they have. See, the discussion we're having can be general, but we're bringing it down to our country and our constitution and the rights that we have. The gap begins with whether we even understand the rights that we have fully. The answer is we do not. For many of us, we still have a hangover from the single-party system where serikali kuu is everything. So as my colleague, and he is my colleague, has stated clearly, it's a process. But this process has to be hastened. Now, the role of government is precisely that. They have to take the lead in it. But you can't vacillate. You can't take the lead and then you claw back on those freedoms again. Yes, the situation with COVID provided that rare opportunity, and truth be told, the government did rise to the occasion. A situation where you have the minister informing people, it was a wonderful thing. Giving out money so that the health services can be improved, it was a wonderful thing. Again, now then we came up with the demon of devolution and devolved health. Money is given, God alone knows where that money goes, because the services for which the money is intended, if it were provided, then the situation that we have wouldn't be exactly what it is. The Kenyan situation is one that has to have where we are constantly dialoguing about it and constantly dialoguing to find out what would work for us. What you quoted for the Chinese worked for them. The Australians worked for them. For New Zealand, worked for them. For the Americans, it's them to decide whether it's working or not. But for ours, we need to entrench these freedoms, and we need people to understand that just like it was negotiated and fought for, when you have a situation that threatens our lives, it's an opportunity to encourage the citizenry to have dialogue with their leaders.
As much as we are talking about balancing rights, you and I have a duty and responsibility to do this and that. So at what point...
I'm surprised you asked that question. The burden of what the citizen's duty is something they carry with them on every single day. That's how they get up and go about their business. They know what their responsibilities are. And these restrictions were infringing on those responsibilities. So they were not able to do what they were supposed to do at the time when they were supposed to do. And even when they did, a lack of understanding by, say, the police force arresting you for being 1 minute late to wherever it is that you're going, and I do not exaggerate here. So do the citizens understand? They very well do. That is why when we have an election, people vote. That is why the citizenry present themselves to the electorate who are fellow citizens so that they can be elected. We do understand our roles, and we really understand it well.
Okay. Siti, and then to Dr. Sultani, is there a case where the restriction of these other freedoms is actually justified, if you look at it case by case? And I'll give you example. In Kenya, we never declared a state of emergency. Many countries did. So in many ways, you could look at our government's approach and actually say they got it right, in the sense that they did not go to the extreme of curtailing many of those rights. What would your response to that be? That case by case, there are times when you can justify this restriction? of these other rights?
If you want to discuss whether the glass is half full or half empty, yes, you can. But if you want to look at how it is, a nation becomes uniquely what it can actually be, what we say exploiting its full potential, then we cannot use standards of other countries without looking for the best and something that we don't have to improve upon. The truth of the matter is that we are in a position to do things that even our neighbors don't do. We are in a position to not just be a leader verbally, but a leader in the real sense in almost every sphere. I am saying this, the situations we find ourselves in with some of these emergencies provide that opportunity.
Okay, all right. Dr. Sultani, are there situations where freedom, the value of freedom, supplants the safety right to health? In your view, are there scenarios that we could say in future where we actually say these other freedoms justify us taking different approaches?
Of course, it is something that we will have to consider case by case, so that we will know that, the movement is exposing, or maybe other freedoms are exposing the population to some public health threats. So what we will need to do is to assess and see how capable are we to be able to mitigate, so that we can now start introducing issues of cost-benefit analysis, at that point. So it depends on how significant the threat is. I can assure you, if COVID was to now, we forget about it and it comes today, we would deal with it very differently. We would probably not lock down anything. Because by the time COVID was coming in early 2020, we had less than 100 ICU beds in the public sector. And they were concentrated in very few areas. But today, we have way more. So we would say, in the interest of making sure that business continues, we can now, look at other measures. Maybe people wear masks, and if you fall sick, we know that you will be able to get whatever you need, whatever care you need in Kakamega. So it is a kind of like on a case-to-case basis. And I just want to maybe quickly borrow from the example that he gave, the one of Sweden. The kind of population you have in Sweden in terms of compliance is very different from the population we have here in Kenya. In Sweden, you can tell them, okay, don't go out. And they listen to you, they don't go out. But in Kenya, you might find the majority actually will listen and stay indoors, but there will be a critical number who will just defy and go out.
All right. I have to bring it to a close at this point. That's it for the questions and answers. Thank you, jury members, for your questions. Now you have 1 minute to give your closing statement. We start with you, Dr. Sultani.
So thank you very much. I just want to thank you for providing this opportunity. This is part of what we are talking about we need to do. It is an excellent opportunity for us to communicate to the public so that we can start engaging and informing them on how prepared we need to be as we go into the future. I just want to say that with regard to what is now hot on our lips, COVID-19, we have done well as a country by all means, and we should actually be able to do better even as we move forward and build back better. But what we need to do is to review our performance and to re-engage. At one point, we actually talked about the several stakeholders. For example, what are the roles of the county governments? What are the roles of national government? Is devolution playing a role in the level at which we are prepared to deal with public health emergencies? Probably this is the time we need to go around a table and review and see how we can sharpen our response system. And then finally, I think I just want to really underscore the need for a whole of government approach. Whether it is health sector, whether it is animal sector, whether it is communication sector, we all need to know that public health is a cross-cutting function. Each and everybody has a very important role to play in maintaining a proper public health status. So moving forward, we would like to see engagement of all the players so that we can be able to do what we are supposed to do. Thank you.
Okay. Thank you. City Muga, your closing statement.
if indeed there's something we've learned from COVID, aside from what my eminent colleague has mentioned, is that Kenyans like to talk, and they all have an opinion on every subject on the planet, and they present their opinions as though they are facts, and irrefutable facts at that. But the reality is that this topic that we speak of, the public health emergencies justify restrictions of constitutional rights. In my mind, it actually provides an opportunity to augment and strengthen the constitutional rights and freedoms, not just of movement, but every other freedoms that our Constitution affords us. And the reason is this. When you know you have the capacity to talk, what perhaps ought now to be brought into the discussion is the capacity to listen. You gave examples of countries like the US where people have the right to speak. There everybody speaks and everybody has a right and it gets a bit confusing sometimes. The ability to listen and to understand is something that can be taught. Yes, and if we do that, then when government speaks, we will listen. When we speak, the government will listen. And then it is a lot easier to arrive at something that we can refer to as a consensus. So, emergencies in and of themselves are not good or bad. It is how we respond to them and how we use that particular platform as an opportunity to make the situation that we find ourselves in better. That, to me, is the crux of the matter.
All right, there you have it. A big thank you to our two debaters for a robust and insightful debate. I think the big question, we started with the jurors skewed towards the affirmative side, and the work was cut for the negative side of this motion to sway the jury members. Have you done enough, City? Let us find out.
At the beginning of the debate, 2 jurors were in support of the motion. 1 juror was against. Have the debaters managed to win over the jurors with their argument?
Well, the jury's verdict is out, and the results on this motion, the closing position of the juror is that 1 jury member is in agreement with this motion, 2 jury members are against the motion. Well, that's it for this edition of We Debate. Thank you once again to our 2 debaters, members of the jury panel, our location host, the Norfolk Hotel, and the KTN team behind this production. And most especially, thank you, our viewer, for participating and staying tuned to this conversation. I am Joe Munene, and I'll see you at the next debate.